Hey guys, thanks for joining us tonight. So my name's Atch. I'm one of the leads in the Med Crash Course series that we're doing. So today we've got Kalpana here, who is a paediatric trainee who's going to go through the finals crash course series for paediatrics. So I'll hand over to Kalpana.
Hello, hi everyone. I'm Kalpana. Thank you, Ashwini, for the introduction, and thank you for giving me this opportunity. And I guess it's a huge thing. So congratulations to actually Med Crash Course for doing all this. You guys doing a good job. So yeah, I'm Kalpana. I'm one of the PEDS trainee, and I thought I might just go through the common conditions that might come up in the exam / also in your clinical years when you become F1, F2, and do PEDS or neonates, it might be helpful. So let's get started. Can you see the slides moving? Yep.
Yep, I can see it.
Perfect. So it's being just very slow. Okay, so these are the topics that we're going to cover. And as you guys know, some of the topics are really huge and broad topics, and I'm just going to give a quick summary, but obviously if you guys have any questions throughout, just stop me and ask me or type in the question. I think Ashwini will flag it up to me, and then I will try my best to answer the questions. So starting with jaundice. So jaundice is a yellowing of the skin or sclera or the gum, and that is caused by a bilirubin that builds up in the blood more than usual. And we define jaundice into two main types, being physiological jaundice and pathological jaundice. Just before we go on to jaundice, I think it might be just worthwhile just to understand the physiology of how the jaundice can happen and where things might go wrong. So red blood cells, we know in adults usually have a half-life of 120 days, but in children it's around 35 days / neonates. And what happens is once they reach their half-life or once they have been damaged, they get broken down in the spleen or the reticular endothelial system and gives rise to two products. One is the heme and one is iron. Iron gets recycled, and it's the heme that gets converted into biliverdin, which is actually green in color, and that gets converted into bilirubin, which is usually red or orange in color. This bilirubin then travels in the blood bound to albumin until it gets to the liver. In the liver, the unconjugated bilirubin gets taken up into the liver cells called the hepatocytes via a special transporter that you find on the cell membrane. And to the bilirubin, then glucuronic acid gets added on by the enzyme glucuronide transferase, and it's now conjugated bili. That conjugated bili then gets pumped out of the hepatocytes via a special efflux transporter, and these then travel through the bile duct and then get excreted in the small bowel in the second portion of the duodenum called ampulla of Vater, where then some of them gets excreted in the feces as sterobilinogen, and that gives us stool the color brown. And majority of that, however, gets reabsorbed, and some of them gets excreted in the urine as urobilinogen. So this is just the pathway of showing. So I don't know whether you can see my mouse. So that's the red blood cells that let's say, gets broken, it's damaged or has reached its end of half-life. It then gets broken down into heme and iron, and then the heme gets converted into biliverdin, then into bilirubin, which then migrates as bound to albumin and then gets to the hepatocytes. At this stage, we call that bilirubin is unconjugated. It gets taken up into the hepatocytes. In the hepatocytes, it gets converted into conjugated bilirubin and then gets excreted via the bile duct into the small intestine, where then some of them gets excreted in the stool, some into the kidney, and majority of them gets reabsorbed. So in terms of jaundice, we can classify jaundice based on the timeline when it has happened. So did the baby get jaundice when they were less than 24 hours of age? Was it after they were 24 hours age, or we sometimes call prolonged jaundice? Prolonged jaundice is when the jaundice goes on for more than 14 days in a term baby and more than 21 days in a preterm baby. That's just for correcting for the gestational age. Or we can classify jaundice as being caused by being a conjugated bilirubin or unconjugated bilirubin that results into jaundice. Or the third way of defining is as depending on the cause, i.e. is it pre-hepatic, hepatic, or post-hepatic? Any questions so far?
No questions so far.
Perfect. So just coming to the causes. So if jaundice happens less than 24 hours of age, usually we think, okay, there's something going on that shouldn't be happening. The commonest reason for why babies at less than 24 of age end up being jaundice is because of ABO incompatibility. What that means is that mom's blood group is different to baby's, and there might have been an interaction between the two blood groups that caused hemolysis of the red blood cell of the baby, and therefore you end up with higher level of bilirubin than you would expect normally, and therefore you end up with higher level of bilirubin. Rhesus incompatibility, again, it's another type of antigen that you find on red blood cells, and another way of how you can divide the blood group in babies. Another cause could be sepsis, probably one of the biggest reasons why babies develop jaundice less than 24 hours of age, and G6PD deficiency or hereditary spherocytosis. If they become jaundice after 24 hours, then usually we say it's physiological. So i.e. The body's just getting adapted to the new environment, getting used to the whole new system. And in majority of the cases why babies end up being jaundice at, let's say, day 2 or day 3 is because they're not getting enough feed. So parents or mom might want to try to breastfeed the baby, but they're not getting enough breast milk. And so as a result, baby can get dehydrated, and that can cause jaundice. But sometimes it could have other underlying causes, and that's when we would think of other causes if the jaundice kind of carries on for more than 14 days or 21 days, depending on whether they're term or preterm, where we think about, okay, is there a hepatic cause? As you guys can see, it could be caused by Gilbert syndrome or Crigel-Najjar syndrome, which I can never pronounce properly, which is associated with the unconjugated bilirubin getting into the hepatocytes because there's a defect in the actual influx transporter, or because there's a defect in the enzyme glucuronide-transferase that adds on the glucuronic acid to the unconjugated bilirubin that converts into the bilirubin, and because of that you might get it. It could be also because of Wilson's disease or hereditary hemochromatosis, hepatitis. As a result, there's a malfunction of the liver cells itself, and therefore the normal conversion of unconjugated bilirubin into conjugated bilirubin fails to happen, and you end up with higher level of unconjugated bilirubin circulating in the bloodstream and unable to be excreted from your body. Or it could be post-hepatic, and probably the most commonest reason post-hepatic and the most commonest reason for prolonged jaundice is biliary atresia. So there is a defect in the anatomy of the bile duct, and therefore even though you were able to convert unconjugated bilirubin into conjugated bilirubin, your body is unable to get it rid of your body because the bile system is just not working, and therefore the bile or the bilirubin is not getting to the small intestine where it can get excreted. Other causes, as you can see, could be metabolic, where you might have other features alongside with jaundice, or endocrine causes like hypothyroidism or hypoandrogenism, or infections like CMV, toxoplasmosis, i.e. congenitally acquired infections, or vascular causes. So how do we diagnose jaundice? So obviously the commonest way of diagnosing jaundice is just by inspection. So you look at baby, either parents notice it, or doctors or nurses or midwives, they notice that the baby looks a bit yellow. And then what you do is, if you pick up the baby being jaundice, the first test usually we do is called something called transcutaneous bilirubin. It's kind of like, it looks kind of like a thermometer, but it's like an infrared that is shown onto the baby's chest and gives us a reading. And if that's high, we usually do a blood test, and it could be either like a gas, a bilirubin, like a heel prick test, like similar to like how we do a blood sugar test, but on baby's heel. And that can give us a quick reading of what the bilirubin is. And sometimes we even do a blood test that we send to the lab to get a level. And then I will come to what that means later on in terms of treatment. Obviously, if the baby goes on to be jaundice for more than 14 days or 21 days, i.e. baby has now prolonged jaundice, we have to do further investigation just to make sure that there's nothing pathological going on. So we do like a full set of bloods, including looking at the total bilirubin, but also looking at the conjugated and unconjugated bilirubin, because that gives us an idea of whether the cause is pre-hepatic, hepatic, or post-hepatic. We also check baby's blood group, G6PD, in specific ethnicity, i.e. like Mediterranean and Afro-Caribbean population. So that's now, next we're going to come to the management. So if it's a physiological jaundice, i.e. a baby that was noticed to be jaundice at day 2 or day 3 of life, as I said to you guys, the most common reason is feeding related. And we usually have this chart that tells us whether the jaundice is high enough where we need to give baby additional treatment on top of just feeding management. And the treatment for that would be phototherapy and exchange transfusion. So phototherapy is like baby usually will be just kept with the eye mask and with a nappy under like special lights, which are like blue lights. These are like special UV lights that can convert bilirubin into bilirubirin, the precursor form, and which the body is much better at getting rid of faster. And in this way, you bring the jaundice, the bilirubin level faster down, rather than waiting just for the feeding to kick in and for the baby to get, for example, hydrated. In very high levels of jaundice, you have to do exchange transfusion, in which case you kind of remove blood from the baby. So you get rid of the high level of bilirubin that the baby has by removing the actual blood, and give them fresh red blood just to make up for the volume, so that they don't end up with like hypovolemia and shock and causing a different problem. Obviously, that is like a kind of like an emergency where you have to act on quite rapidly. Obviously, if it's pathophysiological or prolonged jaundice, you have to also treat the underlying cause and investigate further to find out what the actual cause is. And in prolonged jaundice, even though your jaundice level might be high, you would not treat them with phototherapy or exchange transfusion. You would rather treat the underlying cause. The reason why we iterate so much on jaundice and why it's so important to kind of like treat jaundice and manage jaundice is because of the worry that very high levels of bilirubin circulating in the bloodstream can start to deposit in the basal ganglia in your brain or other parts of the brain, and that can have a significant impact on the baby's development and movement disorders. And so as a result, it is important that we treat jaundice to avoid the complications of kernicterus. And I think that is the end of the jaundice session. I might just do a quick recap of the key summaries, and then if you guys have any questions before I move on to the next scenario, just let me know. So jaundice is an accumulation of bilirubin, and there are two types: physiological jaundice and pathophysiological jaundice. And physiological jaundice usually happens after 24 hours of age, and the commonest reason being dehydration or breastfeeding. If jaundice happens before 24 hours of age, or if it goes on for more than 14 days in term babies or more than 21 days in preterm babies, we think about an underlying cause or something else going on in the baby, and where we think about then, is it hepatic, is it pre-hepatic, hepatic, or post-hepatic? And to guide us to look more into the differentials, it might be useful to find out, okay, is it conjugated or unconjugated bilirubin that is high that leads to the jaundice? So if it's an unconjugated bilirubin that is very high, we know, okay, the cause must be pre-hepatic. And pre-hepatic, we think about like conditions like sickle cell, thalassemia, G6PD, ABO incompatibility, or sepsis. If it is conjugated bili that's high, then we think about hepatic or post-hepatic. So i.e. is there failure of the hepatocytes like Wilson's disease, hereditary hemochromatosis, hepatitis, or is there a failure at the level of the biliary system, or are there metabolic or endocrine causes? And treatment, usually if it's physiological, is treating the feeding as well as phototherapy and exchange transfusion. If it's prolonged jaundice, i.e. more than 14 days or 21 days jaundice that's going on, we would not treat them with phototherapy or exchange transfusion. Instead, we would identify what the underlying cause is and treat that cause. And the reason why we have to treat jaundice is because to avoid the complication of kernicterus, which is deposit of jaundice in the brain, in particular the basal ganglia, which can have neurodevelopmental impact on the baby. So that's jaundice. Do you guys have any questions so far?
Can't see anything on the chat.
Okay. I can just carry on, and then if anything pops up, just shout out, guys. Is it okay, Ashwini?
Yeah, that's fine. If people want to unmute as well, that's fine too.
Oh, fine.
Yeah, they can unmute and ask as well.
Yeah.
But yeah, if you don't want to, you can type it in the chat and I'll relay it.
So next we are going to go to seizure. Again, it's a huge topic. So seizures usually is characterized by like abnormal movements that happens usually due to unusual or unsynchronized electrical activity in the brain. And there are different types. So we have the epileptic seizure, the non-epileptic seizure, which is more like psychological cause, and usually we do not see the unusual electrical activity when we do an EEG. And the most commonest type in children when they have like those seizures, like abnormal movements, is due to febrile convulsion. So I'm going to focus on febrile convulsions. So what is febrile convulsion? The name itself kind of tells us. Febrile means fever, convulsion means jerky movement of the body, and usually it's associated with fever and generally with no infection of the CNS. The exact cause of why these jerky movements happen when children have high-grade fever is unknown, but it is thought that maybe fever can kind of lower the threshold of the electrical activity in the brain, and that might be the reason, but again, the cause is unknown. The commonest reason or the commonest age when we see this is between 6 months to 5 years, and the prevalence in a general population is 1 in 30, but if we have a sibling or parents affected, it's much more higher. Risk factors for febrile convulsion, as I said before, illness. So usually you will notice the parents say that the children might have been unwell for the last couple of days. It could be like a UTI, upper respiratory tract infection, tonsillitis, otitis media, urinary tract infection, or pyelonephritis. They may have meningitis or encephalitis, or they may have had recently vaccinations. Again, the chances are very low. And we usually don't want to scare our parents with that because we already have a huge amount of people or parents who are quite against vaccinations. But this is something that they should be aware of anyways. So yeah, signs and symptoms. So the commonest symptoms that parents would explain is that that they notice that the child might have been unwell for the last few days. They might have been pulling on their ears and they had like a temperature, and then today they noticed the baby had like this generalized jerky movements, which might be associated with tongue biting, incontinence, or rolling of the eyes that parents have never ever seen in their child before. And it would usually last less than 15 minutes, and they would have recovered within an hour. And that might be usually the history, and the history itself is quite strongly suggestive of febrile convulsion. However, sometimes you do have children who might have more complex form of febrile convulsion, where you may have to think of other differentials, in which case parents might say that the seizure has been more focal. They might have recurrent episodes within the same illness. The seizure might have lasted for more than 15 minutes, and they may have taken longer to recover to be back themselves. And so, as I said, generally it's quite a very obvious history, and just from the history, you can diagnose febrile convulsion. But it's very important that you kind of like ask, especially if it's like an OSCE scenario, and they present this case. Make sure that you ask about how the child has been before the seizure, what actually happened during the seizure, so which body parts were involved. The common symptoms of seizure are like tongue biting, rolling of the eyes, incontinence, unconsciousness, or whether with it like well conscious, and what happened after the episode and how long did it last for, and just generally how the child has been before this whole seizure happened, like few days before, and how long it took them to recover. In terms of examination, obviously, if you think febrile convulsion, you want to find out, okay, whether there's an underlying infection that you can point to and say, okay, they might have had like a ear infection that might have caused the high fever, and that's why they had the febrile convulsion. So it's important that you do like a thorough examination, including in children. A very important examination is ear, nose, throat, because that's probably the commonest sites where they get infection. where you would go a bit more deep down and would further investigate and might even do blood tests is if you do not have a clear source for the infection, they're less than 18 months, they have complex seizures, or they have like afebrile convulsions, in which case you might do blood tests like a full set of blood cultures, urine, MSU, chest x-ray, even lumbar puncture to make sure that it's not meningitis or encephalitis that's causing the seizure, and even EEG, especially if you think it's not very suggestive of febrile convulsion. You go down the pathway of, okay, could this be like epileptic seizure or like some other forms of seizure. In terms of management, obviously, if let's say parents came to you, baby has been now had the febrile convulsion, they came to you, obviously their biggest worry is that it might happen again. So advice that you will give them is that they should remove everything around the patient. Do not put anything in their mouth or in their hands, because I think in some cultures, like even like in our Asian cultures, we sometimes have this myth saying putting like keys in the hands of a child or like of the person who's seizing might help it. But yeah, usually tell them not to put anything in their mouth, put them in recovery position and stay with the child and call 999, in particular if it's a prolonged seizure or like airways compromised, but just generally ask them to call 999, and then if possible tell parents to document the duration or sometimes even video record it, because it's such an overwhelming situation that parents just don't remember what happened. So sometimes if someone is able to video record it, at least you can see it and gives you a bit more clear view of what has happened. In terms of if they're in hospital and a seizure happens, you would obviously go down the ABC route, and most importantly, never ever forget glucose, because hypoglycemia could be, again, a high reason for why the child might be seizing. You would also, whilst they have the seizure, do observation, particularly look for SATs, like looking for DSATs, give them high flow oxygen, and then obviously if it's a prolonged seizure going on for more than 5 minutes, we follow the seizure algorithm where we think about anti-epileptics and lorazepam. And if it's, let's say, a febrile convulsion, you would usually observe them for 24 hours and discharge them with parental reassurance. And if it's a first seizure and the child is well and seniors are happy with the story, sometimes they might be even get discharged the same day. In seizures where it was prolonged and has been happening with like quite few febrile illnesses, you might even consider giving parents diazepam to have it in hand. If, for example, you have done like a thorough investigation and there's nothing else that is causing the convulsion and it seems to be febrile convulsion, but the child is just unfortunate that each time the child has a febrile illness that they end up with the convulsion, then you might even think about giving them diazepam, depending on how confident you are with parents handling the situation. And this is just like discharge advice that you would give to a parent. Again, this is more for OSCEs, I would say, in case you have like an explain station. So explain to parents what they know about febrile convulsion, and then explain to them if they don't know anything, or just like add bits and bobs if they already knew most of the stuff, and reassure them. Offer them always a leaflet, give them for safety net advice, so antipyretics, plenty of fluids, remove excess clothes and avoid cold sponge, and explain them to use antipyretics to prevent these febrile convulsions, especially if a child is known to have it. They might want to know about risk of recurrence, so the younger the child, at the age of onset of the febrile convulsion, the higher the risk of them having it again. So as you can see, at if they're 1 year of age, then 50% chance of reoccurring. If they're 2 years of age, it's 30%. And probably the biggest question that most parents will have if a child had a febrile convulsion is whether the child is likely to have epilepsy. And again, statistics show that the likelihood of them developing epilepsy is similar to that of a general population, and the prevalence of a general population developing or having epilepsy is 1%. And then you would also give them just what to do if febrile convulsion happens, i.e. what we just talked about. Prognosis, as I said.
Sorry, just have a question here in the chat. So the question is, when do you need to admit and observe for 24 hours?
I think generally speaking, you would always admit and observe them, especially if it's their first convulsion. It's just like sometimes if the history is like really obvious and the seniors are happy, then obviously you may discharge. But again, generally speaking, from my experience, whenever a child presented with febrile convulsion, we would just admit them and observe them for 24 hours just to make sure that it doesn't happen again. And it's more also for reassurance of parents until they feel comfortable and they're ready to take the child home, I guess. Is that okay?
Yeah, that was the only question in there.
Okay.
Yeah, cool.
Risk factors for reoccurrence, obviously, if there's a family history of febrile convulsion, as we mentioned, if there's a sibling or parent who had it, the chance of the current child having it is much higher than the general population. If the onset is less than 18 months, or if they had a complex seizure, or if they go to nursery, then they're more likely to get more febrile illness, and therefore more likely to have recurrence risk. And if the fever was less than 1 hour or more than 40 degrees, then they're more likely, before the first seizure, then they're more likely. So that is it on febrile convulsion. So just a quick summary. So febrile convulsion is jerky movements of the body when a child has a fever, and that could be due to a viral illness or bacterial illness that they have, could be due to vaccination and as a result having fever, sometimes meningitis or encephalitis. But again, you want to, obviously in that case, you would want to investigate furthermore. If a child presents with a febrile convulsion, it's important that you get a very good history and examine the child. Don't forget an ENT examination. If the story is not very clear or it's atypical, so they have like a complex seizure, so i.e. it's focal, it's going on for more than 15 minutes, the child took more than an hour to recover, or what else? I guess that's probably the commonest atypical forms. Or then obviously you would want to do more investigations. And as I said a couple of times, the risk if a parent or sibling is affected is higher than the general population. The risk of reoccurrence is higher the younger the child is. And the risk of a child developing epilepsy is quite similar to that of a general population. So yeah, and then obviously important safety net advice for parents, and make sure that they understand what to do if it happens again. And if a seizure just generally happens while the child is admitted, ABC protocol, never ever forget to check blood sugar, observations, including SATs, give them high flow oxygen. And then if it goes on for more than 5 minutes, you would go down the algorithm, the seizure algorithm, and start them on anti-epileptics and see how they're doing. And just on that note, in terms of driving and adolescents, so generally speaking, I think the rule is if a child has an epilepsy, they should have been seizure-free for a year before they're able to drive. Or sometimes there are children who might have seizures only at night time. Those children must have had that pattern for 3 years. So for 3 years, they should have had seizures only at night time, in which case those children are also allowed to drive. It just may be a question that might come up in terms of driving and adolescents wanting to drive, or it might be like a question in OSCE stations where you might have a confrontation, just something to know about. Happy to move on?
There's no more questions in the chat.
Okay. Perfect. Okay, I'll just carry on. Please shout out if I'm too fast or if you guys have any questions. So the next topic is birth injuries. Again, there are a couple of different types of injuries that can happen. Superficial injuries, as the name says, just could be like cuts or small lacerations as part of the delivery process, in which case, majority of cases, you don't do much. If it's just like a small laceration, which is not even bleeding and it's not deep, you just like obviously explain it to parents and just keep an eye on it, or just ask parents to keep an eye on it. If they're bleeding like from a small cut, which happened the other day, then you just kind of like apply a bit of gauze until it stops bleeding, and then you can put like clean Steri-strips on it if it's not too deep. So going on to one of the biggest feared injuries is shoulder dystocia. What is it? So shoulder dystocia is when either the anterior or the posterior part of the shoulder kind of gets stuck in the pubic symphysis whilst the baby is getting delivered. And the problem thereby is that usually it is quite hard to get the baby out. And if the baby comes out, sometimes it can happen that because of the force and the way how baby was, that there might be fractures to the clavicles or to the long bones. Or sometimes under the shoulder you have collections of nerve, the brachial plexus that runs underneath, and you can sometimes injure those nerves. And sometimes the other way around, like if the baby is breached, so the legs and the bum gets delivered first and the head gets stuck, sometimes there's also a risk of like hypoxia. And how likely is it that shoulder dystocia happens? It's like 1 in 150 vaginal births, so which is kind of quite common. And this is just how you would normally expect the child to deliver. So i.e. the head comes first, then the baby usually turns around and the shoulder comes out. But as you can see in picture 2, sometimes it can happen that the shoulder gets kind of like stuck against the pubic bone, and there might be a difficulty in getting the child out, and that's when injuries can happen. What are the risk factors? So pre-labor, it could be due to gestational diabetes or mom having diabetes, could be due to previous shoulder dystocia, macrosomia, induction of labor, or maternal BMI more than 30. And during the delivery, it could be due to prolonged labor, vaginal birth, instrumental delivery, or use of oxytocin, which could be risk factors. And what are the symptoms and signs? Obviously, the obvious one might be that there might be difficulties in actually delivering the head or chin, and i.e. there might be a very narrow pelvic bone and difficulties actually getting the baby out. It could be failure of kind of like getting the baby into a neutral position once the head has been delivered, and that's why the shoulder getting stuck, or the turtleneck. So i.e. once the head has been delivered, you can see that the neck slightly retracts back into the pelvis, which kind of also shows that there might be an obstruction for the shoulder to come out. What do you do? So it's an obstetric emergency. So obviously, if any of those risk factors are present, the obstetric team would usually call you anyways, the neonatal team. If it was a normal vaginal delivery, but now you think the baby might be stuck and there's a risk of shoulder dystocia, they will put in obstetric emergency alongside, usually with a neonatal crash call. They might do an episiotomy that's more to create more space for the baby to come out. And then they use the characteristic maneuvering, which is the Mac-Roberts maneuver, where they kind of like tilt, make the mom to lie flat, and then kind of like pull her legs towards her chest. And so in that way, it opens up more space. And they also apply suprapubic pressure, so which is kind of like a pressure on top of mommy's umbilical button, or just above where your bladder would sit. And so it's kind of like pushing the baby out from the top. They might also do other maneuvers, like sometimes they even try to rotate the baby, or they sometimes ask mom to roll to all fours, that again would create more space for the baby to come out. Complications of shoulder dystocia, obviously for mom, is that it is likely that she might end up with a 3rd or 4th degree tear and with postpartum hemorrhage. For the baby, there might be a fracture to the clavicles or the humerus, brachial plexus injury, or brain hypoxia. Is there a question?
Yep. So the question is, what are the causes of congenital hip dysplasia?
Causes of congenital hip dysplasia?
Yeah.
So to be honest with you, I'm not sure what the cause of it is, but there are risk factors. So generally speaking, they say if it's breech, if there is a male, or if there's a family history of congenital hip dysplasia, or I think these are probably the commonest risk factors of why a child can have developmental dysplasia. I do not know what the exact cause is, but if they have any of these risk factors, the child is usually eligible for a hip ultrasound scan, and that will usually happen at 4 to 6 weeks, and to see whether they can pick it up. Or sometimes, even if there's no risk factors, they may do, as part of the baby check, they may notice that the hips are easily dislocatable, or they're already dislocated, in which case, again, urgently you would do a hip ultrasound scan and would get an orthopedic review. And the reason being, what happens in congenital dysplasia is that we know that, like, we have the femoral head that kind of sits within the acetabulum in the hip bone, and then we have the ligament around it, which kind of forms a deep socket. Obviously, that might not be fully formed, and it is thought that the socket might not be deep enough, or the ligament around might not be fully formed, and therefore some children might be more prone for that to be dislocated. But I do not know exactly what causes it. I don't know whether I answered the question.
You got a thank you, so.
Okay. I'm just going to carry on, but yes, please ask questions. I will try my best to answer it. So in terms of mom, obviously, if she had like a 3rd degree or 4th degree tear, or there was a risk of shoulder dystocia, you would do a PR examination on the mom to look for the damage that has been caused, to repair it, and then management of postpartum hemorrhage. It is a very distressing situation for everyone, so there will be a debrief, and mom will have like physiotherapy to help her with the strengthening of the pelvic floor. and there might be sometimes also damage to the nerves, which might be temporarily. And then in the future pregnancy, the options might have to be rediscussed what you want to go for. In terms of babies, obviously, if we think there's a shoulder dystocia or the baby's at risk, as I said earlier on, usually the neonatal team will be present, and the most important thing is that we examine the baby. What are we looking for in the examination is, one, whether the baby is moving all 4 limbs as they should do, whether they have the normal tone, i.e. like the flex position of the hands and the legs. The other one is usually we kind of like palpate around the clavicles and around the shoulder and the hands. And what we're looking for in terms of by palpating over the clavicles, we're looking for a step. If there's a fracture, so we might sometimes feel a step. And by palpating kind of like the shoulder and down the hands, again, it's more to look for tenderness, swelling, and also to look for bruises. Again, it might not be very obvious, and it's very rare that you might even feel a step, even though they might have a clavicle fracture. And you also do like a Moro reflex, which is like where you kind of slightly drop the baby, and the baby would kind of like extend both their arms outwards and then inwards. And then if they, for example, have a fracture of the clavicles, then you usually notice that they would not do it like on the side where it's affected. Or they might have abnormal positions of the affected side, which I will come into later, like Erb's palsy or Klumpke's palsy, which I will come back later. And sometimes if in doubt, or you think there might have been some damage caused, we would still do a chest x-ray, and usually chest x-ray to look at the clavicles as well as the humerus to see whether there are any fractures, because sometimes you might not be even able to feel or palpate the break, and sometimes it's just the chest x-ray that picks it up. We had the other day the case where baby was born normally, NIPE was done, i.e. the baby check was done, and it was noted that baby is just moving one hand doing the Moro reflex, the other one wasn't really moving, and we did a chest x-ray, and it was noted that baby actually had a clavicular fracture. So yeah, these examination might be really helpful to pick it up, but sometimes it's not very obvious. So the other risk of shoulder, sorry,
there's another question here.
Yeah.
What is the difference between episiotomy and tear in terms of the level of injury?
Okay, to be honest with you, this is more of like an obstetric question, but from my understanding, episiotomy is actually, you're kind of like cutting, you're making a small cut from the labia down the skin, like in a particular direction, I think in a 90-degree direction. In that way, you kind of just give more space when the baby comes out, for the skin to kind of open up a bit more, so the baby can come up out much more easier. It's just like kind of like releasing the tension between the skin kind of thing, so giving more space. Whereas a tear is when actually the baby comes out, because of the tension, the skin actually kind of like tears, as the name says. And sometimes it could be so bad that it kind of goes through the muscles. And we had cases where it can go all the way up to the urethra or the bladder, and then the female end up with like incontinence, and they might need like surgical repair of those things. So episiotomy is more of like us doing it to create a space under a controlled way, and whereas tear is more of like a damage that's caused because of the delivery itself.
Just to add to that, the episiotomy can be quite a big tear, like a cut. It's just to protect kind of the anal sphincter as well as the kind of urethra and all that, just so you don't cause damage to the surrounding structures, and just allow that kind of larger passageway for the baby to come out. I think that's the only question.
Yeah, perfect. Okay, so next is brachial plexus injury. So brachial plexus, as we know, is a complex of nerves arising from C5 to T1 that kind of runs under the shoulder. And we usually see C5 and C6 supplies elbow and shoulder, and C7 to T1 supplies the forearm and the hand, and they're responsible for the motor / sensation of the upper limb. And what can happen is, as part of the shoulder dystocia, because you're kind of like pulling on the baby and stretching on the shoulders, sometimes there could be stretch to the nerve that's running underneath the shoulder. That's called neuropraxia, which is the most common form. And generally, they recover within 3 to 6 months. Sometimes you can have actually a rupture, so a nerve cut at the attachment, and which requires surgical repair. And sometimes you might even have like avulsion, where the nerve gets detached from the spine, where you might even have to think about nerve transfer or neuroma, so scar tissue compressing on the nearby nerves, and therefore nerve reconstruction might be needed. And here's just a picture of the different types of rupture, neuroma, neuropraxia, and avulsion. But as I said, neuropraxia is probably the most common one, like just because of the stretch that you might be putting on the child while the baby's delivered, the nerve underneath might be getting stretched as well, but usually that recovers within 3 to 6 months. So in terms of complications, as I mentioned earlier on, Erb's palsy is probably one of the most known complications, which is like also known as the Waiter's tip, which is the damage to the upper brachial plexus, i.e. C5, C6, which causes weakness of the muscles of the shoulder and the biceps, and usually they need physiotherapy to avoid stiffness or atrophy or dislocation. Sometimes you can have like the whole nerves, IC5 to T1 being affected, which is called total plexus involvement, and you can have like loss of motor function of the entire arm. And then you have the Klumpke's palsy, kind of like the opposite to Erb's palsy in the sense that it affects the lower brachial palsy, i.e. C8 to T1, and affects the movement of the hands. And then sometimes you could have pinching at the root, and that causes Horner syndrome, or pinching of the sympathetic nerve in particular, at the level of T1, T2, which can cause anhidrosis, which is kind of like no sweating on the affected side, ptosis, and meiosis, which is a very small pupil. And I think we have pictures. So this is like Horner syndrome. So you can see on the baby's right that the pupil is slightly smaller than the left, and there's a bit of like a droopiness. Then we have Klumpke's palsy, which looks kind of like a bit like the cloved shaped hands. And then you have the Erb's palsy, which is a characteristic Waiter's tip, where you notice that the shoulder kind of like remains attached to the body, and it's kind of like internally rotated in terms of the shoulder. The elbow is extended and pronated, and the wrist is kind of flexed. And here you also get the Moore reflex. But even before you notice the Moore reflex, you might even by looking or inspection, you get that characteristic finding. And what are the risk factors for brachial plexus injury? So large for gestation age, which can be understandable because a baby that's huge might be struggling to come out. Breech birth, i.e. the buttocks getting delivered first and the head kind of getting stuck, and you kind of like pulling on the baby's shoulder to kind of deliver the baby. Prolonged delivery, instrumental delivery, multiple pregnancy, or previous history of brachial plexus injury. What do you do? So usually you observe them, and majority of them recover in 3 to 12 months. As I said, most of the damage is caused due to the nerve being stretched rather than actually like broken or ruptured, and they will require physio and occupational therapy. In some cases, they might even need Botox to avoid contractures or to kind of like rebalance the muscles and help with the motions of the muscles. In a very small percentage, you might even need surgery, like at 3 to 9 months. Osteostomy, tendon transfer, open reduction of the shoulder. That's shoulder dystocia and brachial plexus injury. Now we are going to go to probably the commonest injury that I personally have seen, in particular caput and capsular hematoma. Subgaleal I've seen only on 2 occasions. So what are they? So I think before we go on to the different types, it's just generally speaking, it's a bruising and a swelling noted on the head. But to understand the differences, I might just briefly go through the anatomy. But again, it's just an overview and just very simplified. So starting off, like we can just imagine the head being kind of divided into 3 sections. Like we have the brain, then we have the skull, and then we have the scalp. Starting with the scalp comprises of 5 layers. The outermost layer being the skin. Then underneath we have the connective tissue. Underneath that we have the aponeurosis. I can't pronounce it, sorry guys. Then afterwards we have a loose connective tissue, and then the last layer is like pericranium. And then we go on to the skull, which actually is the bone itself, and the 3 layers that kind of encases the brain, and which are the meninges, i.e. the dura mater, which is the outermost. So I attach the skull bone itself, which is the toughest layer. Following that is the arachnoid matter, which kind of like loosely wraps around the brain. And then we have the pia matter, which is kind of like a see-through sheet that kind of like tightly is attached to the brain, like follows all the gyrus and the sulci. And where the injury happens, it's more towards like the scalp and the skull area. So starting with the caput, it's kind of like fluid or blood accumulation between the skin and the skull, and it's often seen with prolonged delivery, and it usually improves within few days. And some of these children might develop jaundice just because it's a pooling of blood that then gets broken down, and as a result they can have jaundice. Cephalohematoma is a collection of blood between the skull and the skull, and usually subperiosteal collection, and may present after a few hours to days. Again, complications could be anemia or jaundice. And the most life-threatening one is subgaleal, because it's kind of like blood accumulation underneath the aponeurosis, which is kind of like provides a space where it's kind of not like covered on either side by bones or by the hair or the scalp. So as a result, what happens is it's a potential space for just blood to kind of leak into and just get bigger and bigger. And so as a result, you might get like all the blood pooling into that space, and eventually baby going into hypovolemic shock and dying. So it's quite a life-threatening condition that if it happens, we have to keep a close eye. And usually the subgaleal kind of like crosses over the suture lines. And what you also notice is it has a consistency of, like, we usually call it like a boggy swelling. It's like when you fill in a balloon with water, it kind of has that feeling. And who's at risk? Again, instrumental deliveries like forceps or kiwi, or i.e. ventouse delivery. So i.e. like forceps is like the two fork-shaped instrument, whereas kiwi or ventouse are kind of the same. It's like a cup that's attached to the baby's head. And also, or babies who have an underlying coagulation defect or vitamin K defect, they might be also more prone to get subgaleal just because of a small insult, and the bleeding might be just more exaggerated than it would be normally. Then moving on to the next injury is birth asphyxia, which just means, it's a disruption of blood flow to baby, either before, during, or just after delivery, and that leads to hypoxia. And it's important to differentiate between anoxia and hypoxia. Anoxia means no oxygen in the brain or the muscles, whereas hypoxia means lack of oxygen in the brain or muscles. And to kind of like understand the impact that this has on the baby depends on the duration of the oxygen deprivation, the level of oxygen supply, and how quickly one responded to a baby that might be exposed to this hypoxia. So an example would be that a baby that might be just deprived of oxygen for a few minutes might be doing far worse than a baby that might have been exposed for like much more longer, let's say for a half an hour. The reason being is that during that few minutes the baby was disrupted from getting oxygen, it might be that the baby did not get any oxygen, whereas the baby that has been not getting oxygen for 30 minutes might be still getting oxygen, but just not adequate amount. So the level of oxygen, again, the duration and how quickly you responded has all an impact on how well the baby does. And one of the complications, or one of the most worried complications with lack of oxygen going to the brain and the muscles, is something called hypoxic ischemic encephalopathy. So it's because of the lack of oxygen that goes to the brain, the oxygen of the brain cells obviously being starved of oxygen that they rely on, they become ischemic and kind of like dying off and becoming encephalopathic. And in terms of long run, these children might be also the ones who might go on to develop cerebral palsy. What could be causes for a baby to be cut off of the oxygen supply that they're getting from the mother? It could be due to an umbilical cord prolapse, probably one of the commonest reasons why we get like emergency C-section that has to take place within minutes, because otherwise it could be life-threatening for the baby. Umbilical cord compression, meconium aspiration syndrome, premature birth, uterine rupture, infections, prolonged labor, or fetal anemia. All these could be a reason why the child might not be getting enough oxygen than it should be getting. Risk factors is if mom is between age 20 to 25, obviously if there are multiple multiplets, or twins, triplets, or etc. Mom hasn't received inadequate antenatal care, baby is of a very small birth weight, abnormal fetal presentation, or preeclampsia or eclampsia. Signs of symptoms of a baby that might have been not getting enough oxygen at delivery would be that the baby would be born blue or completely pale. Usually has has poor tone, so i.e. like if you kind of like lift up the baby's hand, it just kind of like just drops to the floor with no kind of like gravity effect. And reflexes, so the most common reflex that we look in a baby that's born is moral reflex and sucking reflex, and they might not be present. You might see that the baby is actually not breathing at all, or just making like gasping. Baby might not have heart rate at all, or have a low heart rate, which we define as heart rate less than 100. They might have abnormal neurology, so rather than having the normal flex position, they might have like very floppy, like all extended, or have like abnormal reflexes, or they might have like seizures, or abnormal gas. What we mean with abnormal gas, so when a baby is born and the placenta is delivered, we usually take bloods off the cord, so from the umbilical cord, and we know the umbilical cord comprises of 2 arteries and 1 vein, and we take usually a blood sample of the artery and the vein. And just as a recap, it's the umbilical vein that supplies oxygen to the baby from the placenta, and it's the umbilical artery that supplies oxygen and deoxygenated blood from baby to the placenta. And it just gives us also an idea of what the environment, the oxygen level or the environment was for the baby just before coming out. And usually if they have been acutely deprived of oxygen, you usually notice that their pH is like less than 7.1. And that also gives us an idea with a baby that looks clinically unwell, that this baby has been deprived of oxygen, and that you should be acting on quickly, and that this baby might have a potential of having long-term disabilities or abnormal development. And so what would we do? So if a baby is born in that situation, obviously resuscitation, ventilatory support, giving oxygen, giving some pressure, even intubating the baby in some scenarios. Therapeutic hypothermia, what does that mean? So generally speaking, we don't like babies to be cool. So we usually aim them to be between 36.5 to 37.5. But therapeutic hypothermia is when we actively cool the baby down to like temperature less than 34, and that especially if we think that baby is at risk of having this hypoxic ischemic encephalopathy. So when we think the baby had significant insult to their brain as a result of a lack of oxygen, it seems that cooling the baby seems to have some beneficial effect on the brain's function. I am not too sure what exactly the benefits are, but that seems to be shown in multiple studies, and that's something that we do for babies where we think they might have a hypoxic ischemic encephalopathy. And another treatment, obviously the obvious one that we would say, is obviously giving them oxygen, like high flow oxygen. Normally speaking, in a term baby that's born and otherwise well, or is not breathing much, we would usually hesitate to give like 100% oxygen. But in babies where we think, okay, they might have been starved of oxygen, we would usually go for a very high level of oxygen because they need it. So yeah, that is birth injuries. So just generally a quick recap. So birth injuries, we have starting off with very mild, which might not be mild for parents, but where we might not have to act much on, is like superficial injury, like a small cut or lacerations from the delivery itself, or from the prolonged labor. Then we go on to the commonest injury after that would be probably swelling of the head, so i.e. cephalohematoma, caput, or subgaleal. Subgaleal, again, being quite uncommon, but probably a life-threatening situation if we don't look at this baby carefully and monitor this baby carefully, followed by shoulder dystocia and brachial plexus injury. That is usually with the shoulder getting stuck during the delivery against the pubic bone, and as a result, kind of like might be just pulling on the baby and causing fracture to the clavicles or the humerus, or sometimes the underlying nerves, which are the brachial plexus, getting damaged. And the most common form of damage to the nerves would be kind of stretching it, neuropraxia, or it could be rupturing, and more common. And the complication as a result of that, we can end up with babies having Erb's palsy, total plexus involvement, or Klumpke's palsy, or Horner's syndrome. But again, the commonest ones that we normally see is Erb's palsy. So yeah, any questions so far?
There's nothing else in the chat.
Okay, perfect. I hope I'm not going too fast.
I haven't seen any complaints so far, so think
Okay,
it might be a
fine.
good pace.
Okay, good.
Yeah.
Next, we're going to go on to congenital heart disease. So it's again a huge topic. Again, as the name says, congenital means the babies are born with this condition and it's affecting the heart. And we can divide it into two forms, acyanotic congenital heart disease and cyanotic heart disease. Acyanotic, usually where there is no lack of oxygen and usually no blue periphery or blue, where cyanosis where they usually present with being very blue or pallor and with deoxygenated blood predominating. And so starting with acyanotic, going back, types of acyanotic is atrioceptor defect, ventroceptor defect, patent ductus arteriosus, probably the commonest type of defect that you see in preterm babies. Coarctation of aorta, a syndrome that is related with that is Turner syndrome, and then aortic valve stenosis. Again, coarctation of aorta is not always linked to Turner syndrome, but again, for exams, that might be a link. Cyanotic condition, we have tetralogy of Fallot, transposition of great arteries, and tricuspid atresia. So before I go on to the heart condition, I might just briefly touch up on the fetal circulation. Again, just a quick overview. I'm sorry, I just realized I should have had a picture just to explain better, but if you guys get confused, please ask me. So as we know, when the baby is inside the mum, the gas exchange does not take place in the lung as it normally happens in babies, newborn, or in adults. That task is taken over by the placenta. And the reason being is because the lung is filled with fluids and the lung has its own duty of getting ready once baby is born. So lung is out of the picture. So how does the gas exchange takes place? So it's the mum, so oxygen blood from the uterine artery, if I'm not wrong, is supplying the placenta. And from the placenta, it's the umbilical vein that carries oxygen blood via the ductus venosus, bypassing the liver, going into the inferior vena cava and entering the right atrium. So you enter now oxygen and blood into the right atrium. And as I said, we don't have to go to the lungs. So what happens is the majority of the blood, i.e. 80% of the blood, gets pumped directly from the right atrium into the left atrium. And obviously for that to be able to do, we need a hole. And so there is a hole in the septum that divides the right atrium and the left atrium. So oxygen blood that comes in the right atrium is pumped directly into the left atrium. From the left atrium, it's pumped into the left ventricle. From the left ventricle, it's pumped via the aorta to all parts of our body, or to all parts of the baby's body. And so oxygen blood returns everywhere. However, there's a 20% of the blood that returns in the right atrium that actually decides to go down the normal route of going down to the right ventricles. From the right ventricles, as I said again, there's no need to go to the lungs. So what happens is majority of the blood then again goes from right ventricle into the pulmonary artery and then goes from pulmonary artery directly into the aorta, from where it gets again pumped to all parts of the body. Again, there's a very tiny percentage, like a 1% of the blood that actually does the normal route of right atrium, right ventricle, via pulmonary artery into the lungs, where nothing happens, then comes back to the left atrium, left ventricle, via the aorta, pumped to all parts of the body. And the hole in the between the right atrium and the left ventricle in the fetal circulation is called foramen ovale, and in the hole between the pulmonary artery and the aorta is called ductus arteriosus. So what happens is when the baby is then born and takes their first breath and the lung now actually gets filled with air, actually the change in the pressure, the left now is all of a sudden having a higher pressure than the right side. The foramen ovale usually shuts close, and we say usually within a day, and eventually the ductus arteriosus closes as well. But when things go wrong, that's when we end up with all these defects. So starting with ASD, ASD is when there's a failure of closure of the hole, i.e. the foramen ovale, between that lies between the right atrium and the left atrium. And you have different types, the most common being secundal, which is often when foramen ovale fails to close. But you can also have holes anywhere along the septum that divides the right atrium and the left atrium. So we have the primum, which is kind of found at the anterior inferior or the near AV junction. And that's usually the type of ASD that you see with Down syndrome. or you could have it near to the coronary sinus or the sinus venosus. The reason why that happens in some babies is unknown. Sometimes you notice that there's a family history, or it might be sporadic, or sometimes it could be environmental or genetics. Again, ASD is slightly more seen in females than in males, and it can be either an isolated finding, so the baby just has ASD, or it might be associated with other defects in the heart, like alongside with VSD or with tetralogy of Fowler and many other defects. And usually there is a higher risk of a child developing ASD if there is a family history of ASD. So what are the signs? In majority of the cases, as I said, it's an acyanotic condition. It's usually small. They usually present with no symptoms and might be just picked up because of a murmur, or because the child might be presenting with recurrent chest infection, breathlessness, worse on exertion, difficulties with feeding or tiredness, might have like arrhythmia or atrial fibrillation or palpitations. If it is large enough, it can actually cause pulmonary hypertension because of the hole being open. There's blood volume being pumped from left atrium to right atrium on top of the normal volume that is returning to the right atrium anyways. So you end up on the right side having a higher volume than usual. So which means higher volume of blood has to be pumped through the pulmonary artery, which means there has to be a greater pressure in the pulmonary artery to do that. And that's why you might end up with a pulmonary hypertension. Also with time, it can cause hypertrophy of the right side, and you end up with a right to left shunt, something that you don't want to see, and that's called Eisenmenger syndrome. And you might also have heart failure because now the right side also working very hard and straining. The murmur that I mentioned earlier on, you have an ejection systolic murmur and a split second heart sound. Split second heart sound means we know our heart sound is lup dup. Lup being closure of the atrioventricular valve, i.e. When the tricuspid and the mitral valve closes, you get lup, and dup is when the semilunar valve in the pulmonary artery and in the aorta closes. But because now in ASD you end up with a higher volume of blood has to go through the pulmonary side than through the aorta, and therefore there's a slight delay in the closure of the semilunar valve, and that's why you get the split second heart sound. So you get lup dup dup or something like that. And then sometimes it can also kind of create like a turbulent flow through blood kind of flowing through that hole that can cause a blood clot that then kind of can get stuck into the pulmonary vessels and can cause PE or stroke. How do you diagnose it? So usually either because they're symptomatic or because the child has had that characteristic ejection systolic murmur with the split second heart sound. You actually do an echocardiogram, which is diagnostic. You might do an ECG where you might see a PR prolongation, right axis deviation or left axis in premium ostium or right bundle branch block. Management is usually conservative if the child is asymptomatic and it's small, or you might need a surgical closure with cardiac catheterization, which is the most common way of how we close it, or open heart surgery, depending on the size of the defect, the age of the diagnosis, and the symptomatic. So cardiac catheterization, as far as I remember, it's just like kind of like a small catheter, kind of like threaded through the femoral vein or femoral artery that kind of like threaded through all the way into the right atrium, and it's kind of like it then goes through the hole between the right atrium and the foramen, and then it kind of has a balloon at the end, and then it gets pulled against the septum and it kind of creates a seal, and in that way you kind of closes it. That's what my understanding is of the closure with cardiac catheterization, and it's less invasive than open heart surgery. Generally speaking, children who had a repair during childhood need to follow up into adulthood just to make sure that everything is fine, and they usually have very good prognosis. Similar applies for adults who got it repaired in adulthood, and those who had a small or unrepaired ASD might be followed up until they're like adolescent of age, just to make sure that they don't become symptomatic or it does not change in size and they don't end up requiring surgery. So that is ASD. Okay. So ASD, main point, it's a persistent hole between the right atrium and the left atrium after the baby has been born. And as a result, the child might end up with an ejection systolic murmur and a fixed second heart sound. Generally speaking, the children are asymptomatic, but they might have features of heart failure, recurrent chest infections, or in very severe cases, in unfortunate cases, they might present with stroke or PE. Diagnostic is echocardiogram. You might notice ECG changes, and treatment is either nothing, just keep an eye on it if they're well and there's a small defect. If obviously they're symptomatic or it's large, you have to think about closing it, and that's usually surgically done with either a cardiac catheterization or open heart surgery. Okay, I hope that's all okay. Now we are going to go on to ventroseptal defect, which is a defect in the septum dividing the right and the left ventricle. Okay, so kind of like the opposite end to ASD. Again, it could be either small or large. Children can be symptomatic or asymptomatic, and again, it can be either be an isolated finding or it could be seen in association with other condition like tetralogy or Fallot. Again, you can see a picture here, like I think it's counted as 4, where you have this defect in the septum between the right ventricle and the left ventricle, and all of a sudden you have a direct pathway between the left and the right ventricles. Again, there are different subtypes of where along the septum the defect is. The muscular defect is a defect in the lower muscular part of the ventricle, the more bulkier part, whereas you have the perimembranous part, which is a defect in the upper membranous part of the ventricle, and that is the most commonest form. Sometimes you have an inlet VSD, like a hole near to the tricuspid or the mitral valve, and it may be also part of the AV defect. Do you remember I said in ASD you have also ASD which can be due to defect nearer to the AV junction. And like an AV defect, you often see like an atrioventral defect, you often see with Down syndrome. Or a cornoventricular VSD, which is a hole just below the pulmonary and the aortic valve. Again, cause is unknown, sometimes associated with an underlying genetic condition like Downs, or it could be environmental. Again, children can be asymptomatic. They might present with poor weight gain, generally feeling very tired, being short of breath and having chest pain, palpitations, pulmonary hypertension, heart failure, Eisenmenger syndrome, and paradoxical embolism. Again, similar reasons in terms of the physiology of why they develop these symptoms. And in terms of murmur, they usually have a very large, loud, harsh pansystolic murmur on the lower left sternum with a thrill. Again, diagnostic is echo, and you might see ECG changes, which is a right ventricular hypertrophy, a cardiomegaly with increased pulmonary vascular markings, and sometimes you do an MRI heart, but I'm not too sure why we would do an MRI heart. Management, again, if it's a small defect, less than 5 millimeter, and it's asymptomatic, you go for conservative management. If they have high blood pressure or they have heart failure, you would medicate them and obviously give them high calorie diet, because generally they have poor weight gain and they need the energy. Or surgical, again, same, cardiac catheterization or open heart surgery. Next. So VSD, a defect between the right and the left ventricles. Again, they could be symptomatic or asymptomatic, and management would be similar to ASD. And if you notice, like if they say in the exam that the child has an atrioventricular septal defect with possibly characteristic features of Down syndrome, so Down syndrome should be like one of your top differentials. Now, going to coarctation. So coarctation is narrowing of the aorta. So the aorta is the blood vessel that pumps blood from the left ventricle to all parts of the body. And we can divide it into 3 parts, like the ascending aorta, the aortic arch, and then the descending aorta that then continues to become the thoracic aorta, and then the abdominal aorta. It seems to be more common in male than female, and there's an increased risk if there's a family history. And it's usually associated with bicuspid aortic valve, VSD, or syndromes like Turner syndrome. Signs of coarctation, they also have an ejection systolic murmur with a split second heart sound, as you see with ASD. They might present with pallor, difference in the forelimb blood pressure, the blood pressure in the arms being higher than in the legs, might have cool periphery, hepatomegaly, and rib notching. Symptoms might be poor weight gain, poor feeding, recurrent chest infection, sweating, and chest pain. Again, causes are unknown, but can be genetics. And the pathophysiology for coarctation is thought that, do you guys remember I said that in the fetus circulation, we have usually a hole between the pulmonary artery and the aorta, which is called the ductus arteriosus. And what is thought is, as part of that ductus arteriosus closure, the fibrous tissue at birth might be kind of like narrowing the aorta, kind of like acting like a stricture. And the common area in the aorta where it's affected is usually the juxta aorta, so either the part where it bends from ascending aorta into the aortic arch. History, usually there's a family history, examination, cardiovascular examination, investigation. So on the ECG, you might see left ventricular hypertrophy because of the narrowing. You kind of get like difficulties in the blood volume passing through that narrow or the obstruction, so the left side working even harder, so therefore getting much more bulkier. As a result of left ventricular hypertrophy, you get generally on a chest X-ray a cardiomegaly appearance. Echo might show severe aortic narrowing, and you might do a CT and MRI scan, which can show you more detailed anatomy of the aorta, looking where exactly the defect or the narrowing is. When there's severe coarctation, these children usually present on the first day of life due to the closure of ductus arteriosus and due to the increased workload that the child has, with which they might not be able to cope with. Whereas if the narrowing is not that significant, it might be just picked up later because of like a murmur or an incidental finding of the difference in the blood pressure. So how do you manage them? You might do a prostaglandin, give them prostaglandin, which keep the ductus arteriosus open in severe cases, especially if it has been picked up antenatally. Surgically, you can again do cardiac catheterization to open the narrowing and placing a stent, as you do like in in adults who have myocardial infarction, and you kind of like open the atherosclerotic plaque. You might do an end-to-end anastomosis, so removal of the narrowed part and kind of joining the healthy parts of the aorta together. Or you might do an arch advancement, like so either aorta after narrowing is advanced and anastomosed with the ascending aorta, or subclavian flap out aortoplasty, which is like a patch or portion of the artery may be used as a flap to expand the area. The complications of the surgeries is that despite the surgery being successful, there might be again a restenosis. There might be still high blood pressure, and they may need long-term antihypertensive, or there might be end organ damage during the surgery due to reduced blood flow, because it's quite an invasive surgery and you're operating on a part of the body which is responsible for supplying blood to all parts of the body. Complication generally of coarctation could be recurrent infections, left ventricular hypertrophy and left ventricular failure, coronary artery disease, hypertension in the upper part compared to lower part, aortic dissection, renal disease, brain aneurysm, stroke, and in very unfortunate case, even death. Hopefully that's all okay so far.
There's no questions in the chat.
Perfect, okay. Coming to tetralogy of Fallot, so we are moving on to the cyanotic part of the heart disease. That's probably one of the commonest ones that we are aware of. So it's characterized by ventroceptor defect, right ventricular hypertrophy, pulmonary stenotic stenosis, and an overriding aorta. So that is tetralogy, so 4 defects. So we have the ventroceptor defect, we have the right ventricular hypertrophy, 3 being pulmonary stenosis, and 4 being overriding aorta. Sometimes we have a 5th defect, which is ASD. How do the children present? So usually nowadays it is picked up during antenatal scan. So everyone is prepped for this baby. But for whatever reason, if it hasn't been picked up or it has been not seen there, the children usually present with cyanosis, especially with cyanotic spells or TET spells. So the baby becomes very blue when they feed or cry, like when they become very exhausted, okay, where the energy demand is much more higher. All of a sudden they can't cope with it, okay, because already there's deoxygen blood circulating around, and you usually see a difference in the pre and post ductal oxygenation. As I said, usually antenatally it is picked up and a fetal echo will be done to notice which cardiac defect is done, and so that the baby will be delivered in the according cardiac center. And at birth, you would examine to see whether the baby comes actually cyanosed, the murmur, and to do a pre and post ductal saturation, and you would do an echocardiogram. Treatment is surgery. You would do an open heart surgery where you patch to close the VSD, and it's very important in tetralogy of Fallot that you actually have the VSD, which is a benefit in this case because that allows some mixing of oxygen and deoxygenated blood. And opening up the narrowing of the pulmonary artery and a total repair. Shunt, a small tube placed between the right ventricle and the pulmonary artery to increase the blood flow, and that might be just like a temporary resolution. Or valvuloplasty, again, open up narrowing of the pulmonary artery by pulling wire with inflated balloon. Again, these are just like temporary measure until you actually repair the whole defect. During surgery, the complications are obviously that things might go wrong. There might be damage to the SA node, so they can become bradycardic, and a pacemaker might be needed. Again, it's an invasive procedure, so pneumonia or wound infection can happen, cardiac effusion, endocarditis. Again, you're working with the heart that supplies blood to all parts of the body, and one of the organs that's very sensitive could be the kidneys, and you end up with renal failure or the brain damage. And again, it's a very small risk of mortality. Again, we have to weigh out the benefits and the risk, and in severe and the benefits of operating is probably outweighing the risks that are associated. Long-term prognosis, usually these children do very good and have a good quality of life. Some of them might end up having pulmonary valve stenosis and regurgitation that needs valve replacement followed with anticoagulation. Some of them might have arrhythmia like SVT or VT, which needs anticoagulation and defibrillator, or they might go into heart failure, for which they might need treatment. So again, these children will be followed up probably lifelong. So as we said, so lifelong cardiac follow-up, monitor and treat any complications and reassess the risks, particularly for endocarditis. And if children with who had tetralogy Fallot had it repaired and are going for other invasive procedures, you may even have to think about prophylactically covering them for endocarditis, simply because they are such a great risk of infection. Again, you have to give them advice on exercise and activity, especially if there's like residual leak or narrowing, and they may have to limit the activity. And if the defect has been repaired, in women who are planning to become pregnant, generally speaking, it's a low risk pregnancy, and they still can go ahead as any other woman would go, but they might just have quite a close follow-up. If a previous child with tetralogy of Fallot, then they will have more antenatal scan to make sure that the future pregnancy there's no tetralogy of Fallot. So yep, that is congenital heart disease. It's just quite like a quick overview of the commonest condition. Do you guys have any questions?
There's no questions in the chat right now.
Are we good with timing?
Yeah, that's fine.
Perfect. Okay. So the next topic is slightly a different system, or actually going to the next neighbor organ, which is the lungs. Bronchiolitis is a very common infection that we see a lot of children in A&E during winter period. So it's a lower respiratory tract infection, and the commonest cause is a respiratory syncytial virus, also known as RSV, but it can be also caused by by other viruses like parainfluenza virus, which causes croup, adenovirus, and so on. Usually the onset is less than 2 years of age and seen during November to March period. And what happens is if the child gets infected with RSV, it causes inflammation and edema and mucus secretion that can cause damage to the airway epithelium, that then can cause airway obstruction and distal airway trapping, and therefore ventilation perfusion mismatch. And the child ends up with the signs and symptoms of bronchiolitis. The commonest history that parents would give you is that the child has been having like runny nose, generally like coryzal symptoms, few days, and then they notice that, especially overnight, they notice that the child is not feeding very well, has this cough, quite irritable, and they may even notice in severe cases like difficulties in breathing, so which might be, as mentioned here, apnea, like they might have intermittent pause in the breathing, or they have increased work of breathing, which is characterized by nasal flaring, tracheal tug, or most commonly recession. So like the muscles between the ribs kind of like being drawn in. We call that subcostal or intercostal recessions. They sometimes even have like a low-grade pyrexia, and on auscultation you might hear like a global fine inspiratory crackle and a high-pitched expiratory wheeze. Okay, so an inspiratory crackle and an expiratory wheeze. So when would you admit a child if they have apnea? They don't take 50% of their feeds, or they're dehydrated, they appear seriously unwell, have signs of respiratory distress, have cyanosis, or their oxygen level is less than 92% on room air. What do you do? As we said, it's a viral illness, so no antibiotics. It's usually supportive, so especially if they have respiratory distress, you don't want to feed them on top of it because they're already exhausted, and then feeding on top of it, that's probably not going to work. So in those cases, usually we put either an NG tube in and feed them through the NG tube, or put IV fluids. And in some cases, they may need a bit of oxygen. So if they are more than 6 weeks old, then we give them oxygen if their SATs is below 90% in room air. If they're less than 6 weeks, then we give them oxygen if the saturation is less than 92%. And in some cases where children might have increased work of breathing and they're really struggling with signs of respiratory failure, they may even need CPAP that helps them with their breathing and supports them with the breathing until they overcome the viral illness and the body fights it off. In some babies are eligible for a monoclonal antibody called palivizumab, which is given to high-risk babies, so that are preterm babies who were born less than 35 weeks and they are less than 6 months during the RSV season, i.e. during November to March period, or children who are less than 2 years of age and they require treatment for bronchopulmonary dysplasia in the last 6 months. Bronchopulmonary dysplasia means just chronic lung disease. So they were children with like significant change to the lungs who were like ventilated for a very long time or needed a long-term oxygen supply. Or children who are less than 2 years old and had like hemodynamically significant congenital heart disease. Generally, most children or babies respond very well and recover fully by 3 weeks and do not require treatment. Up to 2 to 3% of babies may need hospital admission in the first year of life, and it's highly contagious. So it's very important that if you see a child with bronchiolitis, especially if they're in the age group, and you should wash your hands before you see your next child. And as I said, the symptoms usually peak at 3 to 5 days, and the cough usually resolves 3 weeks. As we know, cough usually takes much more longer for it to go away, even though we might have completely recovered. So that is bronchiolitis. So quick recap. So bronchiolitis is a very common lower respiratory tract infection. The commonest organism that causes this is called respiratory syncytial virus. The common age is usually less than 2 months of age, generally speaking between 6 to 9 months, especially if they say a baby born who's now 8 months of age had coryzal symptoms presenting with reduced feeding and some feeding and signs of respiratory symptoms. Bronchiolitis is probably high up in your differentials. And treatment is usually symptomatic supportive, i.e. you support them with the feeding via NG tube or IV fluids. If they can't take it orally because they have significant respiratory distress, they may need oxygen supply if their SATs is low. And in some rare cases where there's significant respiratory distress with respiratory failure, they might even need CPAP. And then we have the special group of babies who are eligible for palivizumab, which is like monoclonal antibody against RSV. And these are preterm babies who are 6 months of age or less than 6 months of age during the RSV period. They are less than 2 years of age and have been treated for bronchopulmonary dysplasia in the last 6 months, or they're less than 2 years of age with a significant congenital heart disease. Okay, but majority of them do very well, and the most important thing to remember is that this condition is very contagious, so wash your hands before seeing the next patients, which we should do anyways. I'm going to move on. Any questions?
No, not so far.
Okay, perfect. So the next topic is meningitis. So what is meningitis? It's an inflammation of our meninges, so which is the protective layer around the brain, which is an additional protection to the brain. So what are causes? So causes could be a bacterial, viral, or fungal, and depending on their age, the type of virus or the type of organism that causes meningitis varies. So if they're less than 3 months, the most commonest cause is Group B strep, E. coli, and Listeria. 3 months to 6 years, it's Streptococcus pneumonia, Neisseria meningitis, and H. influenza. Again, H. influenza, very rare now with the immunization. If they're more than 6 years old, Same bug that causes in adults Streptococcus pneumonia and Neisseria meningitis. If they're immunosuppressed, commonest organism is Listeria monocytogenes. So how do these children present? As mentioned earlier on, with jaundice less than 24 hours, irritable, you think, okay, could this be meningitis? Poor feeding, lethargy, stiffness of body and neck, low temperature or fever, very weak suck, high-pitched cry, seizures, or bulging fontanelle. In the children, the symptoms would be more like that, similar to that of an adult or adolescent, so i.e. fever, generally feeling tired, very irritable, complaining of a headache with photophobia, stiff neck, non-blanching rash, and even with seizures. What do you have to do? As usual, history, examination, bloods, and lumbar puncture. Lumbar puncture can give you a huge amount of information about whether the cause is bacterial, viral, or tuberculosis. Okay, starting with the appearance. So the four things that you look at for is 1, the appearance of the actual color of the CSF fluid, the level of glucose, the protein, and the white cell count, and obviously culture that exactly tells you whether there is a bug growing. Starting with appearance, if it's a bacterial, so i.e. bacteria infection or tuberculosis, which is also a bacteria, it usually has a cloudy color. And in tuberculosis, you get this fibrin web, whereas in viral illness, it's usually clear. Coming to glucose, just think about, I usually remembered it as if you have a bug, a bacteria in the glucose, sort of bacteria in the CSF fluid, it kind of wants to use all your glucose so that the brain doesn't have, okay, because bacteria is bad. So in that case, the glucose will be used up by the bacteria, and as a result, the glucose level in the CSF is low, and that's what you see in the bacteria. Whereas in viral, usually it's 60 to 80% of the plasma glucose. So therefore, always remember when we do a lumbar puncture, we usually do a blood glucose test as well. So in that way, we can compare your blood glucose, the blood glucose level in the plasma and the blood glucose level in the CSF. And if the level in the CSF is lower than that you have in plasma, that means then it's not that generally your body had a low glucose level, it's actually that it's being consumed by a bacterial infection. Whereas in viral, you usually have 60 to 80% of the plasma glucose level. Protein level, because bacteria is being very active, it produces a lot of protein. So in bacterial infection, you have it's high. In viral infection, it could be normal or raised. White cell count, again, is high. And in bacterial infection, you usually see polymorphic white cell count. In viral and tuberculosis, you see more lymphocytes. That's kind of like lumbar puncture. And if you have these results given, gives you an idea of, okay, is it bacterial or viral? Like sometimes they just give you LP results and say, okay, is it bacterial or LP, viral? And then they give the age of the child. And based on that, you can then say, oh, okay, this is most likely the bug that's causing it, okay? Just a quick recap. So if you have an LP, look for the color, look for the glucose level, for the protein level, and the count of the white cell count and the type of the white cell count. In bacterial infection, you have, usually it's very cloudy in color because I usually remember it as they produce a lot of protein. And because the bacteria is so active, it needs energy, so it uses glucose. And usually it has a white cell count, which is usually polymorphic in color. With viral, usually it's clear in color. Glucose generally near to normal or just slightly lower than that of a plasma. Protein level is again normal or slightly raised, and the white cell count is usually lymphocytes. And tuberculosis is kind of in between bacteria and viral, more to bacteria. The only difference is that tuberculosis has lymphocytes like viral illnesses. What do you do? Management is usually IV antibiotics if you think bacteria. If in doubt, you might even cover them with both IV antibiotics and antiviral, usually acyclovir being the antiviral. IV antibiotics, usually we use cefataxime, then IV fluids and oxygen. Okay, that's meningitis. Any questions?
No questions so far.
Okay, good.
Yeah, we're getting towards the end.
Yes, we are almost there, guys. Safeguarding, probably one of the biggest topics in children, but also for any patients. So the types of child abuse is physical, neglect, emotional, sexual. Another one is fabricated or induced illness, also sometimes known as Munchausen syndrome. What are the risk factors for a child to be abused? So the risk factors for a child to be abused is if they're usually preterm, they're of a low birth weight, they have a disability, they have been separated from their mother for more than 24 hours after they have been born, and they have another child who's less than 18 months, less than 18 months old. In terms of parents, usually you notice that the parents who abuse their child might be single parent, they might be living with step parents, and they generally live in a very difficult situation like poverty, lack of social support, living in dangerous neighborhood, alcohol, substance abuse, teenage pregnancy. They themselves might have been abused by the caregiver, or there might be domestic violence, low socioeconomic status, unemployment, and low maternal education. And coming to non-accidental burns, probably again a common presentation to A&E. It accounts for 1 in 5 cases of all burns. Risk factors for non-accidental burns is usually, it's more commonly seen in boys than girls. The age group is usually 2 to 4 years of age, and usually they're the youngest sibling. Mechanism of injury is usually a tap water used in 80% of scalded injury, immersion injury, and contact burns. Immersion injury is like the child is literally put into a hot water bath, and usually you clearly see it's like bilateral and it's well demarcated to the point where they have been immersed. Or sometimes if it's like a bathtub, you can have like sparing of the buttocks. Or if it's contact burns, you can see like recognizable object shapes. Yep. The other type of injury is bruising. Common areas where you start to get worried is like buttocks, trunks, genitals, ears, or the back of the hands. Okay, and again, it is usually symmetrical, or again, recognizable objects mark are known. A bruising in a non-mobile child, you would think, how is that? Or like fingertip marks, slap marks, a bruise around the mouth, or torn frenulum. The other type of injury is fractures. So a child who had multiple rib fractures of different healing process, again, non-accidental injury should be coming immediately in your mind. The sites of fractures, usually sternum, scapula, spinous processes. Again, very rare sites for accidental injuries to happen. And again, the type that you have the fracture. So bucket handle fraction, spiral fraction, or bilateral long bone fraction. And then the probably most known one is shaken baby, which we don't call it anymore, just because of how it comes across parents. So it's like the triad of factors like retinal hemorrhage, subdural hemorrhage, and a diffuse brain injury. So that is safeguarding. And obviously, it's very important if you have safeguarding cases, clear documentation, very detailed history, as detailed as possible. Being cautious of who you can disclose information, like in terms of even like parent, school, and everything. So if in doubt, always ask seniors or the safeguarding teams. Clear documentation, very important, date and time of when you have seen the patient, what time, and when everything has been done. Obviously involve everyone you can think of, seniors, nurses, safeguarding teams, social workers, and then even like to get collateral, like in more bigger cases like health visitors, midwives, nurses, all these school teachers, they can all give you very important information. Okay, that's very important. And then again, sometimes taking pictures, depending on obviously you have to get consent, and also use cameras that are kind of confidential, like from the medical legally approved ones. So yeah, next, coming to failure to thrive. Again, it's a huge topic, and that's the last topic. So well done, guys, for hanging around. So things that you want to find out is history. So that gives you a lot of information of in which direction to think about. So starting off when the baby was born. So how old was the baby when they were born? So what gestation week were they, and how much did they weigh? Then you want to find out about the antenatal story. Okay, how was the scan? How were the serology, i.e. did mom had like Hep B, Hep C, HIV? How was mom during the pregnancy? Did she take any medications? Then you go into, okay, baby was born, then you go into the feeding. How are you feeding the baby? Are you breastfeeding? Are you formula feeding? Is it mixed feeding? And if the child is obviously older, you want to find out whether they have been weaned and what they're eating and how they're tolerating it. Then you want to find out about the stool and urine frequency. Sometimes even the color and the type is very important. And then you do a systemic review. So general things that we normally ask: tiredness, weight loss, sleep disturbances, mood, cold intolerance, constipation, diarrhea, pubertal stages. Again, very important to kind of determine whether the age and the pubertal stage that they are kind of like are corresponding. Then examination, you would do obviously a head-to-toe examination, including looking for dysmorphic features in, like, especially if they're like newborns or babies. Head circumference, again, more of babies and newborns. Height, weight, and length, and plotted on the growth chart. Very, very important. And again, important, like in OSCE stations, always mention it. It's always kind of like a bonus point, plus point, because then you can see the trend and see whether they kind of like are falling off the centiles, or is it that they have been always on the lower side, but they're following the trend, which is again reassuring. Once you've taken history, examination, and growth chart, and you think there are things going on, you might want to do blood tests, including thyroid function test, diabetic screen, and celiac screen, especially if there are family history or other autoimmune condition that the child has. So causes for failure to thrive, again, there are multiple causes, so just categorize them. So genetics, Turner syndrome, cystic fibrosis, Down syndrome, physical, like cleft palate, cleft lip. As a result, they have difficulty with actually feeding, and that's why they're not putting on. Or micrognathia, which is like a small jaw. Or it could be at the level of the gastrointestinal system, either difficulties in the absorption, the digestion of the food. So it could be celiac, gastroesophageal reflux disease, esophagitis, Hirschsprung's disease, IBD, cirrhosis, pancreatic insufficiency. Okay, or is it respiratory? Okay, so generally they have a chronic respiratory condition, so therefore they're at risk of recurrent infections and generally being tired and may need more calorie. An example of respiratory condition that can cause failure to thrive is cystic fibrosis, bronchopulmonary disease. Cardiac, again, heart failure. The body needs more energy, it's working much more harder, and they might not be getting the energy, or the food is not adequate, and that might be the reason. Renal, like chronic UTI, renal tubular acidosis. Endocrine, hyperthyroidism, pituitary disorders, growth hormone deficiency, and diabetes. Hematological, obviously you think about if it's more of an acute case and otherwise well child with like blood findings that are more suggestive of like pancytopenia or lymphoblastic or blood film changes, then you think more of malignancy like leukemia, lymphoma, or like if there's a family history of sickle cell, thalassemia, iron deficiency, then obviously you go down that route as well. Newborn babies, which are quite small, like had like generally you notice that they were born at a smaller weight, then you think about infection that might have acquired or may have had during pregnancy that might have affected on the baby. So TORCH stands for the different infective agents that can cause small for gestation age and therefore small babies and generally smaller children. As much as I remember, I think toxoplasmosis, rubella, CMV, and I can't remember H, and then HIV. Social, again, that again should be something in your examination part, looking how the child is interacting, how the child is dressed, the social, the developmental stages, again, an important part of the history. So you think about, is it abuse, is it neglect? Sometimes it's safeguarding things, and as soon as you put the child into, as soon as parents get supported, because they might not be able to afford like good food or clothes, or by actually moving the child to foster carers, you notice all of a sudden the child gets much more better. So that is kind of like indication that actually it was a social reason why the child did not grow and develop as they should do. Or unfortunately, we have cases where it might be just fabricated and induced. Okay, so their parents just make up symptoms and signs that might not be even present, or they actually kind of induce symptoms and signs so that you actually have like clear physical evidences, but there's no explanation. Everything else comes back positive. So that's where you have to think about as well. So yeah, that's all. And these are the references that I have used. So thank you very much then. Any questions?
Oh, there's no questions there. I've just posted the feedback form in the chat, and just a little advert for our next session. So we've got 2 SBA sessions, one covering surgery and one covering medicine. So our next session is on the 9th of February, where we'll be covering some harder kind of key surgery-based SBA questions. And obviously feel free to bring your own questions as well. And we'll be doing the same thing on the 15th for medicine as well. Thank you, guys.
Just a quick one. Just for congenital DDH, I think someone asked, I said the risk factor is male. Actually, it's female. Being a female puts you at higher risk of having DDH.
If you go on to the next slide as well. Yeah, I think that's it. No?
That's it.
Yeah, cool. That's just a QR code for the feedback form as well. Yeah, thank you guys for sticking around. Please do fill in the feedback form. It's really useful for us to improve for next time.
Thank you.
Thank you, Kalpana, for doing this.
Not at
Honestly,
all.
this was great. I learned a lot too.
Thank you guys for sticking around.